Hi, I'm Meredith Vanstone, and this is a recording of the presentation that I made on October 29th, 2020 for the McMaster Midwifery Research Symposium. This project is about an ongoing program of research concerning how people make decisions about cannabis use in pregnancy and during breastfeeding. Start off with some disclosures and a reflexivity statement. This project is funded by CIHR and by the Department of Family Medicine at McMaster University. I have no relationship with any cannabis manufacturer or any person or group with a financial interest in cannabis. Reflexively, because I'm a qualitative researcher and I think it's important to be transparent about this kind of stuff, I'm not a clinician. I'm a researcher who's interested in ethically and socially complex decisions about pregnancy, including decisions about health technologies and drugs. And that's how I come to do this research about cannabis use in pregnancy. I have experienced pregnancy and breastfeeding, and I'm not a regular user of cannabis. This project benefits from a large group of collaborators who include midwives, family physicians, obstetricians, and scientists. I particularly want to acknowledge Janelle, Anu, and Shipra, who are the research assistant team who have been instrumental on the work that I'm going to talk about today. So this project was prompted by the recent legalization of recreational cannabis in Canada at the end of 2018. Cannabis use is high in Canada. In 2019, 30% of Canadians under the age of 34 reported using cannabis once in the previous 3-month period. Following the trend that we've seen in other countries after legalization, we are likely to see this level of usage rise. This is relevant for pregnancy because regular users are likely, somewhere in the neighborhood of 34 to 60%, to continue to use during the perinatal period. Cannabis use during pregnancy, it's really difficult to establish the precise rate of use. Studies report usage rates between 2 and 36% of pregnant people. These rates seem to vary depending on the population studied, the method that they use to collect information on use, how they define use, for example, by frequency or duration. A recent study of Ontario women reported that less than 2% of pregnant women report using cannabis, but this relied on data from the Ontario antenatal record, so it's likely an underestimate, as many pregnant people might not feel comfortable disclosing use to their clinicians. We know even less about the proportion of people who use during breastfeeding. There's little data available about this, but there are some studies that indicate that the majority of women who use cannabis during pregnancy will continue during breastfeeding, and others will reinitiate use during breastfeeding. Why do people use cannabis during pregnancy and lactation? For a variety of reasons, including to treat conditions that they were successfully treating with cannabis before pregnancy, and potentially to treat new conditions that arise during pregnancy. The list of reasons that people might use cannabis therapeutically is long and includes pain, anxiety, nausea, to control epileptic seizures, or for skin and hair treatment. Some people might be under the care of the physician for this use, while others might be self-treating. In addition, people might use cannabis during pregnancy as a form of harm reduction to decrease the perceived negative impact of unmet physical or mental health needs, or as an aid to stop using other substances that they judge to be more harmful. The advent of legalization and commercialization affects the reasons and the ways that people use cannabis, both inside and outside pregnancy. Previous studies of this focused on smoked marijuana, but there's lots of other ways that people use cannabis. As oil applied topically to skin and hair, or ingested through capsules, can be eaten or taken in a tea prepared at home or commercially. There's cannabis candies and beverages, sometimes combined with alcohol, caffeine, or both. So what are the harms of cannabis use in pregnancy? It gets really tricky because the evidence here is still emerging and in many places is equivocal or contradictory. We're challenged here by the confounding factors, including ingestions of other substances such as alcohol or tobacco, and by the reliance on self-reported data about timing, dose, and composition. We're further challenged by the changing composition of cannabis over time to have much higher levels of THC now, making some of the studies conducted a few decades ago essentially about a different substance. In addition, most of the existing evidence focuses on smoked cannabis. What are the maternal risks? For the risks for the pregnant person they're pretty much the same within and outside pregnancy. These risks include respiratory and cardiovascular disorders, as well as mental health and addiction challenges. There's uncertainty whether pregnancy infers additional risk to the pregnant person, although one study showed that pregnant cannabis users are at greater risk for anemia compared to non-pregnant users. Most of the time when we're talking about risks to the pregnancy, to the fetus, or to the infant. Evidence here is still emerging. There have been contradictory findings on whether the use of cannabis during pregnancy has effects on birth weight, stillbirth, miscarriage, preterm birth, a decrease in birth weight, or increase in admission to the neonatal intensive care unit. For all of these outcomes, there are some studies showing positive association with cannabis use and some studies showing no association. Later in life, children with prenatal exposure to cannabis may have executive functioning problems with attention, hyperactivity, and impulsivity in early childhood. They might have emotional and behavior problems and be at higher risk for autism spectrum disorder. There are also studies showing no association with these outcomes. What are the risks of exposure through lactation? Well, we know that THC is highly lipophilic and transfers into breast milk, although it's unclear whether or not this is true for other cannabinoid compounds. There have been very few studies looking at the harms of cannabis exposure through breast milk. Those that exist have conflicting results, with one study reporting decreased motor development with cannabis use and another reporting no effect on developmental outcomes. So where does this leave us? The general population is using cannabis more frequently in the past, and this use will likely increase after legalization. We don't know how many people are using cannabis during pregnancy and lactation, but we can anticipate that this use will also probably increase over time. The evidence about the harms of cannabis use during pregnancy is uncertain. While there are many studies, the evidence about these harms is equivocal and often contradictory. The evidence that exists focuses mostly on smoked marijuana during pregnancy, which leaves a variety of questions about the harms of other forms of cannabis use, about the harms of cannabis use during breastfeeding, and about the effect of timing, dose, and duration on harm. Here are some of the relevant clinical policies. All three organizations state that women who are pregnant or contemplating pregnancy should abstain from cannabis, and the American Academy of Pediatrics and the American College of Obstetricians and Gynecologists clarify that there's insufficient data to evaluate the effects of cannabis during pregnancy and breastfeeding. But this nuance doesn't seem to have translated to the public health materials and the public education materials, which pretty strongly state that cannabis should not be consumed during pregnancy. We can understand why the patient education materials have taken this tack. The precautionary principle tells us that if we don't know something is safe, it's better to err on the side of caution and not to consume that substance. For occasional users of cannabis, it makes sense to exercise this caution and just to cease use during pregnancy. But what about the people who have compelling reasons to use during pregnancy? The people who might be using cannabis to alleviate pain, anxiety, control seizures, or decrease nausea? What about people who use cannabis in order to stop using other substances that we know are more dangerous, or who live in a context where ceasing cannabis use would result in other forms of physical, social, or mental harm? Pregnant and lactating people face a challenging decision about how to modulate their cannabis use. Healthcare providers might struggle to counsel on this topic in a way which does not generate stigma or destroy the therapeutic alliance and acknowledges the uncertainty of evidence, reduces harm to all members of the family, and encourages the client to make their own decision about what is best for them. This brings us to our research project. So over the course of the next 3 years, my team is investigating how pregnant people, their partners, and their prenatal clinicians navigate the decision about cannabis use during pregnancy and breastfeeding. We're doing this through 2 mirrored studies, one which focuses on the experience, beliefs, and opinions of pregnant people and their partners, and one which focuses on the perspectives of prenatal clinicians. Each study begins with a systematic review, which will inform a later primary qualitative study. Today, I'm going to share findings from the systematic review of the perspectives of pregnant people and their partners. So in the systematic review, we searched a series of medical and social science databases. And because this is a new and emerging area of research, as well as an area of research that does not have a lot of consistent terminology, we also hand searched a variety of journals, and we searched backwards and forwards in the citation lists of the eligible articles that we identified. In this review, we included studies which were published in English and which were peer-reviewed full-text primary publications. They needed to focus on pregnancy and/or lactation, and they need to focus on cannabis use in any form or cannabis combined with other substances. We included studies that focused on the perspectives of pregnant or lactating people and or their partners. We excluded non-empirical publications and studies that were not about cannabis use during pregnancy or lactation, as well as studies that were not about the attitudes of pregnant people and their partners. There's a nuance here. There are a variety of studies about the perceptions of citizens or the lay public about cannabis use in pregnancy, and those were excluded from our review. We were particularly looking for the attitudes and the perceptions of pregnant people and their partners about cannabis use during pregnancy, because we think that pregnant people think about this differently than members of the general public. Just briefly, our analytic strategy, and I'm happy to share more information about this, but I wanted to focus this presentation on the findings. So what we did is we used a convergent integrated synthesis approach to this review of mixed methods research. That means we treated all of the studies the same analytically, and we worked with them together. In order to do this, we used Sandalowski's method of qualitizing the data by identifying and extracting findings and then transforming each of those findings into a portable declarative statement that's understandable on its own. Here's our Prisma diagram. From nearly 4,000 citations, we identified 23 eligible studies, and a good number of those came from our hand searching. In terms of our 23 eligible studies, most of them were published in the US, although they represent jurisdictions with a variety of policies on the legality of medical and recreational cannabis use. We also had some studies from Australia, Canada, and Jamaica. These studies include a reasonable mix of qualitative, quantitative, and mixed methods papers. The quantitative research is nearly all survey research, which makes sense because we're studying perspectives, beliefs, and opinions. These studies describe the perspectives of about 10,000 pregnant people and their and really no partners, actually. It was all pregnant people or postpartum people. We didn't find any studies which specified that the participants were breastfeeding or were speaking about previous experiences breastfeeding, although sometimes this was implicit in the specific details that they gave in the quotations. And so we have a variety of findings. Our first findings is that we have an empty review about partners' perspectives, that this is just not present in the current literature. We also have an empty review about perspectives of use of cannabis during lactation. Accordingly, the findings that we do have focus on pregnant people's perspectives on cannabis use during pregnancy. So as we worked our way through analysis, we identified rich data about how and why people use cannabis in pregnancy, where they go for information and how they evaluate it, what factors influence them to start, stop, and continue using, and how they interact with this topic around their healthcare, with their healthcare providers and with their social circle. Within all of these topics, we found significant variation. At times, it was hard to parse the analytic thread across these very divergent studies. We then started to pay attention to the context of the individual research. We looked to see how the social historical context of the study, including the jurisdiction and the time when it was conducted, the legal status of cannabis in that jurisdiction, the disciplinary background of the researcher, the funding source, the objectives, and the assumptions. And we engaged in comparative analysis to try and account for the divergence that we were seeing in these studies. We mapped and remapped the studies and identified that one of the main factors which influenced the finding were the comparator groups of substances that were studied. More than author discipline, legal status, year, country, funding source, the way that cannabis was grouped with other substances influenced the findings. And this makes sense because these factors likely shape whether the researcher considers cannabis to be a herbal remedy alongside chamomile tea and ginger, or an illicit substance similar to methamphetamine and opioids. Of course, the comparator groups were chosen by the authors, and they don't necessarily reflect the way that participants understand cannabis. An illuminating quote for me was this, from a 2020 study conducted in the state of Washington where cannabis use is legal. Participants described using cannabis in moderation during pregnancy, cutting back use and making informed decisions about their consumption. They compared cannabis use to caffeine and fast food consumption and contrasted it to cigarette and alcohol use. With both caffeine and fast food, we understand that consuming these substances as part of the lives of people before pregnancy may fulfill important needs and may be difficult to stop without encouragement, support, and a really clear reason to stop. We understand that fast food and caffeine are suboptimal for pregnant women. And the participant quotes which follow the statement in the Barbosa-Leica paper described quitting smoking and drinking as soon as pregnancy was known, but moderating cannabis use rather than quitting it altogether because the benefits were received from cannabis use and the risks were unclear. So reading this quote was a real light bulb moment for me in analysis, and I started thinking about the way that we compared cannabis to other substances influenced what we found. We then went back to our data and we recoded our papers in comparative groups, looking for how the texture of our research question changed when cannabis was considered on its own or alongside other substances. Here are the groups that we identified. We had 12 studies that looked at cannabis on its own. We had 3 studies which studied cannabis alongside alcohol and tobacco, 2 substances which are legal, commonly used, and with very strong evidence of deleterious effects for mother and baby. We had 6 studies which looked at cannabis alongside other illegal substances, including methamphetamine, cocaine, and opioids. These studies did not typically specify the substances of interest, but tended to speak in generalities about substance abuse or illegal drugs. We then had 2 studies in another group. Both of these studies were about the same participant group, and they include cannabis alongside a list of herbal remedies and alternative medicines, including herbs such as chamomile and ginger. When we looked at our data according to each comparator group, we started to identify very different findings. The comparator groups influence what was sought, and so of course they influence what was found. For example, most of the studies in the other illicit drugs category sampled participants who were in substance abuse recovery programs. Many of these participants experienced social and economic hardship that was not addressed as a relevant factor in, for instance, the herbal and alternative medicine studies. Then we analyzed each group independently, paying attention to the main decision that was faced by the pregnant people, how they discussed harm, how they discussed benefits, what decision-making factors were deemed relevant, and how information was sought and used. These are the findings that I'll present. So in the group that included cannabis alongside tobacco and alcohol, we had 3 papers, all funded by organizations with explicit missions to stop substance use. Accordingly, the main decision faced in these studies by participants was whether or not to stop consuming cannabis during pregnancy. The harms of cannabis were clearly stated. Harm to the fetus was the main consideration, with harm to own health, addiction, stress, and withdrawal symptoms from quitting also addressed. Few benefits were discussed, but individual participants mentioned that cannabis helped treat depression, manage stress, and forget problems. When considering whether to stop or reduce use, social factors are important, with the concern or lack of concern from family and friends mentioned as influential. Information seeking to help make the decision is not mentioned in any of the articles. There's an implicit assumption that information is not needed, that the choice to quit or at least cut down is clear. Despite the fact that recreational cannabis use was illegal in all 3 jurisdictions at the time that data was collected for these studies, legal issues and concerns of state intervention are not mentioned. The adolescent participants in one study are worried about getting in trouble for their cannabis use, but this is not explicitly described as legal trouble, more social censure from parents. The next group includes cannabis alongside other illicit drugs, and this group of studies did not focus on a particular list of substances, but rather reported long list of substances that participants discussed using, which often included alcohol and tobacco. However, use of alcohol and tobacco alongside cannabis alone would not make a participant eligible for these studies. 5 of these studies were conducted in the US and 1 in Canada. 2 were conducted in jurisdictions where recreational cannabis was legal. 4 were medical and recreational cannabis was legal. And of these total 6 studies, 5 recruited from substance use treatment programs. 2 of those 5 also recruited from government social service agencies related to pregnancy and parenting. There was 1 study that only recruited from those social service agencies related to pregnancy and parenting. This collection of studies started from the assumption that quitting substance use was necessary and desirable, and examined the barriers and facilitators of quitting. Accordingly, the main decision faced in these studies was not whether to quit, but how, and what the impacts of quitting were, such as decreased access to prenatal care. There was very little discussion of the benefits of substance use or why women chose to use substances in these studies. One woman in the Canadian study mentioned that she consumed cannabis and food products because it treated a condition that she couldn't afford her prescription medication for. Others mentioned that substance use was a coping mechanism and helped relieve stress. Relationships with people who use substances was cited as a factor which normalized and made substances difficult to quit, although this wasn't framed as a benefit to use, more as a barrier to quitting. Perceptions of the harms of substance use in pregnancy were frequently discussed in this group of papers. Participants discussed drug-related arrests, and criminal involvement, including an overwhelming fear of Child Protective Services taking their child away after birth. This was a very common theme in the American papers and was mentioned in the Canadian paper as well. Participants also discussed perceptions of the harm to the fetus and their feelings of worry or guilt about this. Some participants denied feeling worried about harming their baby, citing other children they knew to be prenatally exposed to similar substances without observable harm. Because the main decision considered was how to quit, not whether to quit, the influential factors in this decision focused on available support and resources to quit, and perceptions of self-efficacy about quitting. Similarly, content about how information was sought, evaluated, and used focused on seeking information about how to quit and what resources were available to support quitting or to support sober parenting. Only one study mentioned pregnant people seeking information about the consequences of substance use on the fetus. The small group of cannabis combined with herbal and alternative medicines contained 2 studies of the same group of participants. Cannabis was one of a variety of herbal remedies considered by participants to treat nausea and vomiting in pregnancy. When making the decision about what to use to control nausea, participants discussed harm to the fetus as a primary concern and efficacy of the herbal medicine as a secondary concern. They made the decision based on prior knowledge, trusted sources of advice, and intuition or instinct. Participants were more comfortable using herbs than pharmaceutical drugs and would turn only to pharmaceutical products after herbal medicines had failed. The legal implications of cannabis were not discussed, although medical and not recreational cannabis was legal in this jurisdiction at the time of the study. Our final group and our largest group is studies which discuss cannabis only, and I'm going to spend a little bit more time on this group. In this group of 12 studies, 5 were conducted in jurisdictions where recreational cannabis was either legal or decriminalized. 5 were conducted in jurisdictions where recreational cannabis was illegal, and 2 were conducted in multiple jurisdictions. These studies are mostly American, with 2 from Canada and 1 conducted in Jamaica by an American scholar. 5 disclose no external funding, 6 have funding from the National Institute Against Drug Abuse or another anti-drug organization, although 4 of those 6 also disclose funding from a general health organization or a state department of health. The main decision that participants were grappling with in this collection of papers was how to change their cannabis use in order to maximize benefits while decreasing risk. For some participants, this meant quitting altogether, but others talked about changing the form of cannabis that they used. For instance, to teas, away from edibles, or to sativa rather than indica strains of cannabis. They also discussed changing the amount they consumed or using cannabis only at particular stages of pregnancy in order to minimize risk. These decisions were made in a careful calibration of risk and benefit. In terms of benefits, this group of study was the only group to offer in-depth analysis about the benefits that pregnant people perceived from cannabis use. These benefits included managing conditions that pre-existed pregnancy, including anxiety, depression, bipolar disorder, substance use disorders, PTSD, insomnia, anemia, chronic pain, H. pylori, osteoarthritis, and fibromyalgia. They also talked about cannabis as important for their general health and mental, physical, or spiritual well-being. Some pregnant people used cannabis to manage conditions or symptoms specifically related to pregnancy, including nausea and vomiting, weight gain, sleep, pain related to the physical toll of pregnancy, and stress related to pregnancy and parenting. For example, participants in multiple studies talked about cannabis as a necessity to control nausea so that they were able to consume the nutrients that their baby required. One study offered that some women were interested in using cannabis to control pain during labor. These benefits were balanced against the perceived harms of cannabis. Here, harms concentrated in 2 areas. The first area is the potential harm to the development of their baby, which included both the harms caused by cannabis, but also the harm that could be caused by withdrawal or by substituting another substance for cannabis. Participants in several studies preferred the natural composition of cannabis to pharmaceutical medications or other substances. They discussed using cannabis to alleviate the potential harm of consuming opioids or prescription medications, including anti-nausea medication and non-steroidal anti-inflammatories. Participants also discussed the potential harm of legal or criminal involvement, including Child Protective Services. Beyond this balance of harms and benefits, pregnant people also made their decision about how to use cannabis based on their pre-pregnancy habits and reasons for use, their financial circumstances, and the interaction from family, friends, and healthcare professionals. For some, cannabis use improved their mood, provided pleasure, and helped manage stress, and made difficult circumstances more tolerable. It was often more affordable or attainable than other ways of achieving these same outcomes. In making this decision, pregnant people sought out information from a wide variety of sources, including the internet, friends and family, and healthcare providers. In places where cannabis is sold legally, employees of cannabis dispensaries were also seen as a source of information. Reconciling conflicting and confusing messages was necessary, as was deciding what to do about gaps in information. Participants in many of these papers recognize the existing gap in evidence, wishing that the clear, concise, and direct information available about tobacco and alcohol use in pregnancy was similarly available for cannabis. For participants in all of these groups, there are compelling reasons to use cannabis that clinicians should take seriously and consider in the context of their client's life and their perceptions of risk and benefit. In terms of implications, I think the biggest lesson for clinicians and researchers is to think carefully about the way that their preconceived notions of cannabis and the reasons why people might use it during pregnancy or breastfeeding shapes the way that you ask about it, counsel it about it, or design research about it. The way that you ask the question, whether that's a question to a client in clinic or a research question, will shape the answers that you receive. As someone who researches socially and ethically complex decisions in pregnancy, I have tremendous admiration and respect for Midwifery's commitment to supporting clients in making informed choices about the way that they live during the perinatal period. I really love that they have time to take as a profession to get to know somebody and to walk with them through these very complex decisions. My take-home message for the clinicians today is that a commitment to supporting informed choices in pregnancy requires an examination of the assumptions and preconceived notions that you have, assumptions and preconceived notions which are shaped by your own experiences and background, but also by public health messaging and the way that evidence is created and communicated. We know that there are many barriers to supporting pregnant people in making informed decisions about using cannabis in pregnancy or while breastfeeding, but one that every clinician can work on are the assumptions that they bring to that small question on the Ontario antenatal record. Here is a long and illegible list of references and a list of the papers that are included in our review. I value your thoughts and feedback as this research program is just getting rolling. So here's my email address, our study email address, and an advertisement for our primary qualitative study about decision-making about using of cannabis during pregnancy or breastfeeding. And I'd also like to acknowledge that all the pictures in this presentation are from unsplash.com, which offers copyright-free pictures. Thanks for listening.